All right, and we're rolling. Let's go then. So as usual, each week we'll cover the previous week's content. So this is all going to be week 1 stuff we're revising. Okay, so this time we're talking about intercostal catheters. This one's a bit of a mean one to start off on, so don't worry too much if you don't know exactly. All right, nice. I think
awesome.
Yeah, perfect.
Yeah, sorry, this is my question. Absolutely right. So if you're doing prolonged drainage, so this is like more long-term drainage of pretty much anything like air, blood, fluid, whatever it is from the pleural space, the buzzwordy sort of landmark is the 5th IC space anterior to the mid-axillary line. The one that I expected a couple of people to click, which I've seen here, is the 2nd intercostal space mid-clavicular line. That's more for like a rapid decompression, especially of like a tension pneumothorax. So you do that first, like in an emergency acute setting. But then once that's done, you can go to the 5th IC space anterior to mid-axillary line. So well done for everyone who chose either A or B, because in some respects, they're both done.
Nice. And yeah, new participants, new people who joined, feel free to hop in. We're leaving unlocked, so just use the pin in the bottom right and hop in.
Also, if you disagree with anything that we say, or like you want to add extra stuff in, just like feel free to unmute, because yeah, like I could say something completely wrong.
Yeah, exactly.
Yeah.
So this one is more about clinical presentation. I think probably the relevant video to this one is clinical anatomy of the lungs and pleura, if I'm correct.
Yeah.
Yeah, perfect. Okay.
Yeah, well done. Okay, so I guess there's 2 major distinctions to make here. The first is about the difference between parietal pleura-referred pain and visceral pleura-referred pain. So remember that the visceral pleura is not very sensitive to pain at all. It only produces like a really dull, localized ache. And it's more sensitive to things like stretch, which makes sense because it's around the lungs. So your body needs to know when it's overstretched the lungs, understretched the lungs, whatever. Like it's kind of like a feedback mechanism. With the parietal pleura, though, it's important that we know whether there's some sort of pathology there, whether it's some sort of like stabbing, whatever it is, you can know that there's pain because it's quite well localized and sharp. The only difference is that there are kind of like 4 regional areas of the parietal pleura that you need to be aware of. And I've listed sort of like 3 of them here, or like a couple of them, not all of them. When you just think about the innervation of the nerve, like the nervous innervation, it's quite straightforward because there's only 2 nerves that will innervate the parietal pleura. That's the intercostal nerves that kind of wrap around, following the ribs. And then you've also got the phrenic nerve. And if you remember from our thorax anatomy, which we would have done this year and last year, you'll remember that the phrenic nerve is sort of more medial. So that kind of helps you to remember, because of the fact that intercostals are lateral, phrenic nerve is medial. The mediastinal parietal pleura, which is medial as well, that's going to be phrenic nerve innervation. Cervical is generally more intercostal. Peripheral diaphragmatic, remember there's like central diaphragmatic, peripheral diaphragmatic. If it's on the outside, it's lateral, which means it's probably going to be more intercostal nerves that are innervating those. And kind of like the third layer to this is, you remember phrenic nerve, kind of like the embryology behind it. It started off in the neck, so, and then it dragged along with the diaphragm. So if you have phrenic nerve innervation, it makes sense that you would have pain around the neck, as well as the jaw, as well as the tip of the shoulder. So there's a couple of layers to unwrap there, but I hope that kind of simplifies the thought process.
Awesome. That's a really in-depth explanation. And well done to Platypus God, who is currently in the lead. Hopefully some of you guys are soon on the board. All right, Highland.
Oh, this one's mean.
Yeah. I mean, but it's also good because this is really high yield. They love giving you, here's the lung hilum, what's what, or in the hilum, you know, what is in what relationship to other things. So it's a good one for you guys to learn.
Yeah, amazing. So majority of people chose the correct answer, which is really reassuring. I realize I probably should have put a picture in here just to contextualize what I'm saying. But I think if you just like search up hilum structures, left versus right lung on your internet right now, you would be able to see, yeah, awesome. Thanks, James. You would probably be able to see like a really good image that shows how the pulmonary artery, the pulmonary veins, and the main bronchi are arranged. Yeah, that's a really good one. So the major, I think I like in the slides, I probably gave you a couple of steps that you can use to be able to, like, say you're in a dissection lab and you've been just like given a lung at some point, and you can look at the hilum to be able to figure out whether it's a left or a right lung. Obviously, you can look at the number of lobes, but that's besides the point. So you look at the hilum, and one of the easiest ways to figure out if it's left or right is using this mnemonic called RALS. So when you have the right pulmonary artery, so RA and then LS, right? So right pulmonary artery is anterior, so that's the R, that's the A, to the main bronchus. So yeah, as James is pointing out there, if you look at the right artery, it's going to be right in front of the main bronchus. Whereas if you look at the left side, if you look at left pulmonary artery, it's generally going to be superior. So left, and then S is for superior. So that's probably the easiest way to figure it out. And then the veins, they're kind of just quite posterior in relation to everything else. So that would be the main way that you can differentiate. But there is a lot of variation. And I've found that when we've gone into dissection, sometimes that doesn't work. But in an ideal world, that would be the way that they're arranged.
Do you mean posterior or anterior, the veins?
Oh, sorry. Wait, did I?
I think antero-inferior, sort of.
Oh, yes, sorry. Anterior inferior, not posterior inferior. My bad. Yeah. Yeah, thanks, James. That should be anterior.
Yeah. A good landmark, if you are just looking at like a whole lung and you're like, I have no idea what this is. This big sort of flat bit here, that's the spine sort of area. So that's always a good landmark. And yeah, so like the veins are pretty easy almost because they're always anterior and inferior, whereas the bronchi and the arteries, those are the ones that have different relationships, and that's why we use the RALS mnemonic. Yeah,
and just stuff. Like while you're there, James, really quickly.
Yeah,
awesome. So like just to also highlight the fact that there's a bunch of impressions on the lungs themselves. Not really important for your exams, but when you get to dissections, like someone might just ask you like, oh, what is this impression made from? And like the main way you can think about it is like, what would be on this side of the mediastinum, like left side versus right side. So classically, if you look at some of these ones, you might be able to make out the arch of the aorta, the descending aorta. You may even be able to make out the azygous vein, like at least the impressions of them. So just a good idea to kind of know about that if you get asked, but really not that high yield.
It's like a cast of all the stuff. So you've got the aorta there, you've got the IVC there, sorry, SVC there, all sorts of stuff. Easy. Right. Nice, good stuff. And yeah, you people feel free to join using the link at the bottom right. This one's going to lung function tests. There's one of these answers that I hope nobody picks.
I think I know which one you're talking about.
Yeah, we'll see. Very nice.
Okay, wonderful. I don't think there's much to explain here then, but the main thing is that carbon dioxide does diffuse quite well. And I guess the way you can remember that is like people get carbon monoxide. Did I say carbon dioxide? I meant carbon monoxide. People can get carbon monoxide poisoning. So it obviously has to diffuse into the blood at some point. And it's not generally going to be in the bloodstream. So if it can diffuse and there's not enough of it in the bloodstream to kind of confound however much gets into the blood, it's a really good way to figure out how much is diffused. And so it's a measure of diffusion. Whereas helium doesn't diffuse through, it stays in your lung. So if you keep pumping helium in and eventually at some point you won't be able to pump anymore, that can give you an idea about the total lung capacity, which is why B is, or blue is not correct.
Nice.
Awesome.
Okay, we're getting some movement. Okay, VQ matching, which is also a really good high yield thing.
Yeah, awesome. So I want to first talk about green because I feel like that's where most of the answers went. so the question is, or the option is, when VQ is too low, the lungs will respond by increasing ventilation. So, I mean, ideally that makes sense, right? Because if your numerator, and if you increase the numerator, you're going to increase the total VQ ratio, which obviously will increase the ratio itself. But the lungs don't kind of work that way. What they do is, if you have some sort of decreased ventilation, which would be the reason why VQ is too low, it's kind of difficult for the lungs to then like increase ventilation, because there's probably some sort of pathology that's stopping you from getting the ventilation in the first place. So the way that it tries to maintain the matching is that it will actually decrease perfusion. So if you imagine you decrease the denominator, that will also increase the ratio. So it's just a matter of thinking, okay, why is VQ low in the first place? Generally, it's because you've got a decreased ventilation. And that decreased ventilation is for some reason, which it's probably outside the lungs that the lungs just can't magically fix. So how is it going to ensure matching remains? It's going to look at the other factor, correct that, so that you have some sort of matching happening. For yellow, the difference here is that, and this is the part that confused me quite a bit as well when I was in your shoes, VQ is generally the lowest at the base of the lungs. And I would have talked about the reasons why that's the case in our lecture, but it's also closer to the optimal like 0.8 value that the lungs just prefer to work with. So that's the difference, the distinction to make. Just because your VQ ratio is lower doesn't mean it's bad. The base actually has closer to 0.8. Whereas if you look at sort of the apex, it might be like 2, which seems good, like really good ventilation. But of course, it means you've got a lot of ventilation, not enough blood actually being there. So that's wasted air. So that's the difference. And I think I might just quickly go to red because one person picked that. In the presence of a pulmonary embolism, VQ is likely to be less than 0.8. So in the case of a pulmonary embolism, you would have reduced blood flow. So you would have Q, which is the perfusion variable, being lower. And so overall, the ratio will be higher. And in this case, would be higher than 0.8, not less than. So hopefully that clarifies things a bit. Well done.
Awesome. Okay. We're still very neck and neck. Could be anyone. Do we have the writer here, the author of this question here? Maybe not. Yeah, I mean, it's basically what it says on the tin. So the oxygen dissociation curve sort of looks like an S shape, which is a sigmoid curve. And that's basically because there's a minimum, there's a maximum. And so we can't keep going up forever. We can't keep going down forever. And so we sort of flatten out near those areas. Exponential would mean at some point, like you just become insane at taking in oxygen. And hyperbolic would be really, really weird. So yeah.
Just an important, oh wait, let me just check that there's no question about this. Yeah, just an important thing to keep in mind about the shape itself. It's clinically relevant because if you have like your O2, like the reason why we say that 94, below 94 for your oxygen sats is a bad thing, is because if you try and map that 94 onto the curve, if you go any below that, you kind of get to the slippery slope part in the middle of the curve, which means any lower than that actually represents a massive decrease in the oxygen saturation of the red blood cells themselves. So I would encourage you to not only think about the shape of the graph, just like physiologically, but also why is that important for us to know? And why do we have this number 94 in the first place, that we're worried about patients going under and experiencing hypoxia? Yeah.
Perfect. All right, oxygen dissociation curve. This is actually quite high yield. They do like giving you questions on this one. Interesting. Okay. Do we feel from this one or? Okay, so basically, everything comes back to exercise. Like you can imagine, almost everything except for the 2,3 DPG, everything else that shifts things to the right is basically stuff that would happen when you exercise. So because if you remember, your muscles create lactic acid under strain, your pH is going to decrease, it become more acidic. You can increase temperature because you warm up when you're exercising, and you can increase CO2 because you're undergoing cellular respiration at a very high rate, and so you have more carbon dioxide there. 2,3-DPG is sort of its own thing, like you just have to understand that one on its own. The reason it's not increased ATP is just because that's not strictly relevant. If anything, increased ATP would mean you don't need more oxygen in your cells over there because they already have a high rate of cellular respiration. Yeah, so basically it comes down to that. The important thing to understand, like the question can't speak today, like the question them suggests, is that the rightward shift means that you're actually giving more oxygen to the area. So the reason that we correlate stuff that happens in intense activity to increased dissociation is because intense activity tells the body, hey, you need to drop off more oxygen here. And so all of these signs are things saying, hey, this is working really hard, give me more oxygen. So well done to everyone who got that one right. Nice. Yep. Not much to say for this one. You guys are all on top of it. We have such smart second years. All right. Well done. Well done to Perry. 6 correct answers in a row. That is impressive. Nice. Guys,
all right. Yeah, that was my question. So I can quickly talk about this. I think it's pretty self-explanatory. We've covered it in the lecture. A bit of a caveat here is that technically you can have active contraction of muscles during expiration, but that's more during respiratory distress when your abdominal muscles, for example, might become involved. But if you're assuming, normal breathing without, high work required for it, you'd be thinking about just inspiration and the diaphragm mainly contracting. And that's why the answer there would be inspiration only.
Yeah, perfect. And I don't think there's a question on this one. So if I can stray a little bit into history, or rather examination, you can look at a patient and see during the general inspection, are they using other muscles? So normally all you're going to use is the diaphragm. And so what we call the accessory muscles of breathing, stuff like your sternocleidomastoids and all that sort of stuff. If they are being used in addition to your normal muscles, your diaphragm, then that means something's gone wrong. So you're in respiratory distress, your body's saying, oh my God, I need to work way harder. And that's a good sign that something's wrong with their lungs, basically. Yeah. Streak continues. When will it end? New arrivals, as always, join during using the link in the bottom right.
All right, let's have a think about, first of all, what does the word lung compliance mean? The word compliance refers to the fact, characteristic of being able to be easily opened up with the lungs. So in this case, factors that would increase lung compliance would make them more easily open up and expand. And in this case, aging and pulmonary fibrosis are two examples of factors that actually cause the opposite. Pulmonary fibrosis makes sense because you have more thicker connective tissue, which sort of limits expansion. And you do have greater elastic recoil, but you also have it being much harder to sort of expand the lungs themselves. In terms of aging sort of has two main effects. One is that it generally reduces lung compliance, like through fibrotic changes, but also with age, you have this separate change, which is the thoracic cage due to calcification that comes with aging, and also muscle wasting. So you've got like sort of weaker intercostal muscles. Those things can limit the expansion of the thoracic cage itself, and therefore limit overall lung expansion. And then those two factors make aging actually decrease lung compliance. Elevated sympathetic nervous system activity, that doesn't really play a role here. And C refers to increased surfactant production. So if you remember about this chemical is reducing the hydrogen bonding between water molecules within the alveoli. So it's reducing the surface tension, and therefore it's making it easier for you to overcome that force and expand the alveoli and expand the lungs overall. Yeah.
Perfect. Okay, so yeah, a really big thing that I had to understand in second year was that breathing actually has everything to do with pressure and almost nothing to do with mechanics.
All right, so we have a bit of a split of answers. I can quickly talk about, first of all, why we wouldn't go with our answers as being either of A and B. So A and B are talking about intrapulmonary pressure changes and talking about those pressure changes being throughout inspiration or expiration. The problem is with intrapulmonary pressure, during inspiration and expiration, they do change, but those changes are transient, or they only occur temporarily and they go back to zero within inspiration and within expiration. The reason is that your lung space, or thoracic, or your intrapulmonary space, is an open cavity. It's open to the atmosphere. And so what that means is if you have a dip in that pressure below atmospheric pressure, it'll return back to zero because there'll be a compensation which occurs, which is that air comes in, and then you'll have equal pressures inside and outside. You might have learned about this over and over again with osmosis, with so many different theories, which is that things like to move down pressure gradients. And it's the exact same thing happening here. So because you have an open space, you're actually going to have your pressures eventually equalizing. And so they're not going to stay rising or stay dipping throughout inspiration or expiration. But if you're talking about what actually happens during inspiration, the intrapulmonary pressure actually is dipping, and that's what allows air to come in. And during expiration, the intrapulmonary pressure is initially rising, which is what allows the air to exit and go down that gradient. The answer is going to be D here, because if you think about intrapleural pressure, this is the referring to the pressure within the pleural space. And again, just a reminder, it's normally negative. But during expiration, this is kind of a weird idea, but during expiration, what actually happens is if you think about your visceral pleura and parietal pleura, they both are moving out. And so even though you might think that your visceral pleura might come and meet your parietal pleura and the space would decrease, you actually have the net effect being that your parietal pleura moves out more. So you actually have an overall volume increase. And so your pressure actually drops during expiration. And so that's why the answer there is C, which is that it actually rises during inspiration for the opposite reason, which is that when it comes back, the volume decreases. Bit of a long-winded explanation there, but I hope that made sense. If it doesn't, have a look at the video or let us know in the chat, and we'll try and sort that out.
Perfect. And yeah, sorry about the meeting time thing. I don't know why it's doing that. What we'll probably do is we'll just stop it at 40 minutes, and then we'll start it again, and it'll be the same length. So just come right back, and we'll keep going. So apologies. We'll try and get that sorted for next time. Might have to move to Google Meet or something. All right. This one is, how can we describe the presentation of this particular patient?
All right, so this question's asking about two things. First of all, we're characterizing the cough in terms of timing and whether or not it's productive. So in this case, we do have a productive cough because bringing something up with it. So we know it's going to be from either of B or C. So it's not going to be A or D because they're both dry. And then it's a matter of the fact that they both are acute just tells you straight away the answer has to have acute in it. And just as a reminder, the word acute and chronic, they kind of differ based on which source you refer to. But generally speaking, acute is less than 3 weeks or less than 1 month, so 4 weeks. And this is well below that. So we're going to still have an acute cough here. And then with regards to whether it's hemoptysis or frank blood just means blood on its own, whereas hemoptysis means it's a more general term, and it can refer to blood mixed in with, for example, mucus, which is what's happening in this case.
Perfect. Lots of movement on the board. Still got 5 questions.
James, you also have another question about the intrapleural pressure, so I might explain that maybe after this question.
Sure. Looks like we're pretty confident with this one. That's a good sign. Nice.
All right, great job, everyone. Yeah, the answer is blood nose epistaxis. The reason I put this question in is because with respiratory history taking, they're thrown a lot of new terminology. And so it's really important that you understand what each of those things means, because you're going to be using them during your OSCEs and during your exams to characterize a particular patient and what they're going through.
Perfect.
We might quickly pause here and talk about the plural.
Yeah, go ahead.
Question. Yeah, so I think it's they're asking for an explanation about intrapleural pressure. So I actually found this a bit confusing at the start as well. So let me try and explain it in simpler terms. So if you remember what the pleura are, there's 2 layers, the parietal pleura and the visceral pleura. The parietal pleura is stuck to the outside thoracic cage, and the visceral pleura is stuck onto the viscera or the lungs itself, the organ itself, right? So the visceral pleura is going to move with the lungs because it's on the lungs, whereas the parietal pleura will move with the thoracic cage because it's stuck to the outside thoracic cage. So that's an important part you have to understand. Next is that during inspiration, we know that our lungs are going to expand. So we think that your visceral pleura is going to move out towards your parietal pleura. And so the conventional thinking might be that because your visceral pleura is getting pushed out during expansion of the lungs and coming up to the parietal pleura, you have that pleural space in between them decreasing. But what actually happens is that even though your visceral pleura is being pushed out during lung expansion, your parietal pleura is also being pushed out, because if you think about breathing in, if you try doing it right now, your thoracic cage will also expand during inspiration, right? Because your muscles are contracting to increase the space within your thoracic cage. And so you actually have both of them moving out. And the overall net effect of that is that you actually have a net increase in volume, because your parietal pleura, the outer one, moves out more than the visceral pleura moves out, if that makes sense. So you get a net increase in volume as you inspire. And if you remember, an increase in volume causes a reduction in pressure. So that's why during inspiration, your intrapleural pressure drops. And then you can use the same logic for expiration. And that explains that case as well.
Perfect. I think we'll squeeze in one more question and then we'll stop and restart. So there is actually quite a lot of overlap between respiratory and cardiac, and when you eventually make it to hospital, you'll see there are a lot of patients that have both cardiac and respiratory issues. But they're sort of very codependent on one another.
Awesome. Yeah, so everyone got B and C. There was some confusion about A and D. Now, cough is definitely a respiratory related sort of symptom, but we don't conventionally put it under cardiac. The same with pain in your ankles, that's sort of more related to things like peripheral vascular disease, and so more cardiovascular, the vascular component of cardiovascular. And chest pain is asked about in both of them, because if you think about the viscera being affected or damaged or ischemic in some way, it's going to cause chest pain. And if you think about shortness of breath, that's also related to both of them, because with respiratory pathology, you can have some sort of obstruction going on, some sort of infection going on that causes that. But with cardiac, you might have things like heart failure, which is causing a similar thing.
Perfect. And so we're going to restart there. So hop off and come right back in maybe 30 seconds or so. Catch you all in a minute. Perfect. Okay. We're back and we'll hop on to the next question. All right. So this is integrative medicine, everyone's favorite topic. And we're talking about evidence in medical research. So if you remember that big pyramid, that's basically this. Okay, I'm pretty confident with this one. I like the sound of that. Interesting. Okay. Yeah, I was wondering if I'd catch out a couple of you guys. Looks like I have. So RCT is very good. They're pretty great. And they're the highest standard of evidence for a single study. Because unlike cohort and case control studies, we are actually doing a good job of controlling other variables. So like, obviously you try to do that in cohort and case control, but it's much, much harder to prove causation. Systematic reviews, however, get their own little tier because they are multiple studies. So you're basically taking the sample size of multiple studies, the controls of multiple studies, and you're getting all the benefits of having multiple smaller studies sort of rolled into one. And of course, as with anything, if you have more data and it's good data, then you'll reduce the amount of random fluctuation every time you increase the size of data. Okay. Now, the note here is that systematic reviews do depend, like the quality of them does depend on the studies that you put in them. So if you introduce a bunch of really crappy RCTs or case series or something to your systematic review, then you're going to get bad data out, like junk data in, junk data out. And that's why we are really strict usually about what sort of stuff we put in a systematic review. And when you read a systematic review, they're meant to tell you what sort of studies they included and what sort of criteria they had sort of for accepting certain kinds of studies or rejecting certain kinds of studies. Awesome. Okay. Nice. Okay. So, yep. Effectiveness is the ability of the treatment to work in real life conditions. Blue is efficacy, which is like if you do it in a lab, it'll work. Of course, if things don't translate from the lab to real life, then there's not much point in pursuing them. Green is efficiency, which is sort of like very tied to cost effectiveness. Orange/yellow there doesn't tie to a particular term, so we don't have a jargon term for describing how well a treatment fits a particular patient, but it is an important concept. So always when we talk about EBM, you remember one of those three circles that we talk about is making sure that the treatment is actually suitable for this particular patient. Awesome. And one more, and then we'll hop over to the lung function questions before we wrap up. Okay. So if you remember your PICO, usually you have O for outcome, something that you want to measure. Interesting. Okay. So I'm glad knowing you picked blue or green. So relief of symptoms is obviously quite good in terms of an outcome. Quality of life increase, also quite good. Now, red is actually a valid thing. So like if you have chronic kidney disease or something, if we increase your filtration rate, then that is actually a good thing. Or if we reduce the amount of damage, something like that. That is actually a thing that we can use as a valid outcome. Now, the reason that cost to the patient is not a valid outcome is because it has more, it's something that exists sort of independent of the outcome. So in general, when it comes to the O, we don't sort of weigh a bunch of different factors. We pick one factor and we stick to that one. Cost to the patient is impossible to treat as one factor because it doesn't tell you anything about how well the patient actually got treated, if that makes sense. Yeah, okay, so one moment, we're going to switch over to the lung function questions and then we'll return for our final leaderboard. All right, give me 1 second. Okay, can you guys see that?
All right. Sweet. Thanks, James. for setting that up. So, okay, we have this first question. This is straight from the slides, adjusted a little bit. So we've got these spirometry results. FEV1 is 2.5 liters, FVC is 3 liters, total lung capacity is decreased, and DLCO is decreased.
Yeah, so just check your answers in chat for this one. What do you think of ILD, chest wall asthma, sorry, chest wall disorder, asthma, or even a combination of the above? Okay, I've got one a private message for A. Anyone else agree, disagree? Could be any number of things. Another one for A. Anyone going to go against the grain? Or are we all happy with A?
All right.
I reckon we're happy with A.
That is all. I reckon we go with A, and that's correct. So let's walk through this. So you've got an FEV1 ratio of 2.5/3. We can make that 5/6, and that is actually an increase in the ratio from 80%. I mean, if you do the maths, like 1/6 is less than 1/5. So you've got an increase in your FEV1 over FVC ratio. Even if it was the same, it would still indicate a restrictive disorder, since if it decreases, you're looking at obstructive. Now, if you've cornered it down to a restrictive disorder, you've got A or B left. And then you look at DLCO, because the difference between interstitial lung disease and chest wall disorder, they're both restrictive. So how do you differentiate between them is that ILD will have a decrease in the oxygen diffusion across the alveoli, while chest wall disorder won't. And so the fact that DLCO is decreased is what then makes you eliminate B and can get you back to A. All right, next slide, please.
Nice.
Yep, direct reading from a spirometer cannot be used to measure which of these values.
Okay, I'm getting a private message for C.
Mm-hmm.
Anyone want to agree, disagree with that one? Again, we're getting some concordance in these results.
Good.
That was an
We'll have to
integrated
make them more
medicine joke.
challenging next time.
Yeah, we gotta test you guys a bit more. You guys are too on top of things. Perfect. All right, click through the answer.
Yes, please. And it's C. Okay. Did you get the image up in the slides, James?
I thought that was for the third question.
Yeah. Okay, that's perfect. So I'll go through this with the image later on. So if you
Sure.
just move on.
Yeah. Right, last question, and then we'll use the image, because there is really just one image for lung function test, which pretty much explains everything. It's pretty fantastic.
Yep. So the sum of these three values is
All right, I'm getting an answer in private message for D.
mm-hmm.
I wonder if we'll get same or different. Controversial,
Yep.
this one. Anyone have an idea? You have a 1 in 4 chance of being correct, no matter what you take.
Let's give it 5 more seconds, and then we can move on.
All right, I think we're going forward with D. Let's see.
Sweet. All right. If we get that image up, and I'll walk through it. So this is the one Holy Grail diagram that will describe all of spirometry to you. So if we go through the first question, that was about what cannot be measured on spirometry. So the bottom horizontal line below the expiratory reserve volume signifies the amount of volume that's left in your lungs after you've forcibly expired as much air as possible. And so that's the amount of air that isn't really being used for breathing to keep you alive, but it's just being used to keep your lungs patent. And so that is a measure that we can't measure on spirometry. There are some special mechanisms, but it's really not that clinically relevant. And so anytime the arrow sort of dips below that bottom line are the values that you can't really measure on spirometry. So your main one is your residual volume, which indicates solely that volume that's left in your lungs, holding them open. Your functional residual capacity, which is the amount of air left in your lungs after passive breathing, when you exhale after passive breathing, and total lung capacity is fairly intuitive. So if you understand this diagram, and a lot of the words, a lot of the descriptions are actually fairly intuitive, and spiratory reserve volume is how much air you have that you can inspire. The second question was about the sum of these three values. So these are your three main values, which is the tidal volume, or in this diagram, total volume for some reason, your expiratory reserve, and your inspiratory reserve. And that's essentially known as your vital capacity. And all you need to know about vital capacity is that it is the amount of air you can forcibly inhale and exhale using voluntarily, essentially. Now, I think if I might just add on a point towards the end here, I think the respiratory system is one of those systems where you really realize the importance of understanding, because a lot of the concepts in physiology can be a bit complicated and take a bit of visualization and understanding the difference pressure biomechanics to be able to answer a bunch of these questions. And so like Janum or Janel or James, in any of their questions, they would have explanations for why the answer was what it was, and it's not just memorize this pressure, the intrapleural pressure. You sort of need to understand how it works and why it is what it is to be able to understand how to manipulate it. And the reason that physiology or respiratory system as a whole requires that much is because if you mess up one little thing in memorizing of a single value, it can alter the answer so much. So there are a few things you'll need to memorize, like 0.8 is the magic number for ventilation perfusion, but like the whole concept of ventilation perfusion and like it being lowest at the base is all based on gravity. If you understand how gravity works and affects blood and alveoli, you can figure that out. You don't really have a time limit per se on exams. It's a lot of time. But yeah, I thought I'd just finish on that note.
Perfect. And yeah, if you guys can see the blue squiggles I've put up on the diagram, that's just to show you why you can't see the residual volume, basically, or the FRC, or stuff derived from that, basically, because what you get on the spirometer is actually the blue stuff, and so when you look at a spirometry out reading, you can only see the top part of this, and that means you never actually get to see how much volume there is left. So if you're confused as to like why can't we tell when it's clearly there on the graph, that's why. All right, let's hop back up to Kahoot to see who won. All right, let me know when you guys see it. Yes, maybe, hopefully.
Oh, sorry, you just cut out. Yeah, we can see it.
Perfect. All right. All right, well done to Carrie. 14 out of 17 is really good, actually, given that you guys have only known this stuff for about a week. So good going. As usual, we'll open up to questions. I can already see one in the chat. So we'll stop the recording in a moment, and then you guys can ask whatever you want. We'll be doing this every week. Next week, we'll try and shift it over back to Tuesday at 6 p.m. And we'll try and keep them short and sharp, so never over an hour, and hopefully under like 40, 45, so that you guys can get in, do a bit of revision, and then get out to enjoy your night. So perfect. Feel free to hop off or stick around if you want to see our answers to those questions.